About 26% of healthy women with low-risk pregnancies still undergo C-sections, despite the potential risk to mothers and babies. To avoid unnecessary C-sections, hospitals are making strides in recognizing risk factors for mothers and babies sooner. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hetterly, Senior Writer with AHA. In this Members in Action podcast featuring maternal and child health efforts, we're speaking with Dr. Stephen Lockhart, Chief Medical Officer of Sutter Health. Dr. Lockhart will discuss Sutter Health's commitment to improving outcomes by reducing the number of first birth C-section rates through its Pregnancy and Childbirth Services, in addition to engaging mothers and their families through the process. Dr. Lockhart, it's our privilege to have you join us today.
Thanks so much.
Let's jump right in. Can you tell us about your initiative to reduce the number of C-sections for first-time births? When did you start it, and what prompted you to do it then?
Our initiative around reducing C-sections for first-time mothers really is an extension of a longer-term process we started in Sutter Health. In 1999, we started what we called our first pregnancy and delivery initiative. And it was really geared towards creating better outcomes for mothers and babies throughout Sutter Health. And in Sutter Health, what we did was we created essentially a community of improvement or a community improvement committee for our women's and children's program. As you know, Sutter Health is an organization that has 22 hospitals and across a wide geography in Northern California, urban and rural facilities alike. And so there was a need to kind of collaborate and standardize across our system. So this was a big part of our variation reduction with starting this first pregnancy and delivery program. In the first 2.5 years of the program, our cesarean section rate at our largest delivery service, which is in Oakland and Berkeley, the Altabate Summit Medical Center, declined from 25% to 18%. And that served as a great impetus for the entire system and started our process of continually improving the work. And I might mention also that the leader of what we call our Sutter Health Women's and Children's Group, nicknamed SWAG, but it's really that collaborative within Sutter Health of all of our obstetricians, gynecologists, anesthesiologists, informaticists, lab, and so on. That group was at that time headed by Dr. Elliot Main, who is the head of the California Maternal Quality Collaborative, the CMQCC. So essentially, the process that he started within Sutter Health is what he then went and did statewide and has had huge success starting in 2006, and we can talk about that. But yes, we started this a long time ago, but I think the key issue here is really that focus on quality, the focus on variation reduction, and really getting buy-in from all the clinicians. As we improve, we're going to all participate.
With the C-section rates declining for first-time births, what other outcomes have you seen with regard to incidents of maternal morbidity, postpartum recovery, patient satisfaction, or any other measurable?
Well, in the same time period, we experienced a decline in patients being admitted in very early labor, which is less than 3 centimeters dilated, from 40% down to 29%, which is important because once admitted, there's a bias to aggressively move towards delivery. If patients in, we want to get them delivered. And that can lead to the use of oxytocin and all of those other things that then can lead to cesarean sections or induction of labor. So we found reduced episiotomy from 25% to 10% with a consequent decrease in third and fourth degree lacerations. Patient satisfaction went up. We were able to do things like initiate breastfeeding earlier for our cesarean section moms. And also we saw our length of stay go down from an average of more than 4 days for cesarean section to 2 days for vaginal birth. So there were a lot of side benefits. And I think the lessons that we learned from that really have to do with building culture and teamwork. And this is the same kind of collaborative mindset that one needs to have happen across different organizations, which is, of course, what CMQCC is about doing. They're about taking different health systems and having them work together. Within Sutter Health, working together, but also the culture of the actual labor and delivery deck is extremely important. And I think that was a large part, and we did some survey work to demonstrate this, is a large part of our ability to reduce C-sections. because we created a culture around expectations of the moms. We created a culture around what the expectations were of the physicians. We created a positive culture around the use of nurse midwives and the collaborative work that they can provide for the birthing team. And also the nursing team that is obviously very, very involved in something like labor and delivery. They're kind of really the very, very frontline monitors and decision makers on how things go. Bringing them all into the same mindset made a huge difference.
What have been some of the challenges and unexpected improvements from this initiative?
Well, some of the good surprises, goodness sort of generates more goodness. It's a virtuous cycle. So as we get better outcomes and results for our patients, our clinicians are happier because they feel they're providing better care. Our patients are happier. And then that fuels this sort of notion that by working together, we can provide better care. And I will say that this particular clinical improvement group is one of our earliest and most long-standing within Sutter Health. And therefore, what I find now is that when we do have initiatives or things that we want to address to improve quality, they immediately suck it up. There's a pull from this group to say, what can we do better? And then once we've agreed on that, the implementation has been really rapid and effective. I think the other thing that we've sort of seen has been, and this is obviously not the reason that we make quality improvement work, we do it for the benefit of our patients, but we also found that our obstetrical claims showed a significant decrease. And of course, that's the largest single area of lawsuits in healthcare. So those are some of the more positive outcomes that we've seen. I'd say some of the challenges really are all the usual challenges in change management. There are challenges around making sure that I think it's important to have effective leadership and leadership that is highly respected within your clinical community. That was certainly true of Dr. Main and now Dr. Lana Cruzan, who head up that improvement group. But it's really important that those leaders are willing to stand up and sort of say, no, this is what we need to do that's best for our patient. I know you like to induce your patients before 39 weeks because it makes you very popular with a certain group of patients that you can sort of market yourself to, but we're not going to do that because that's not the best care. And have your colleagues stand up and say those sort of things. Those are some of the challenges that we've had, but I think given the history over the last now 20 years, that kind of resistance has sort of melted away.
Moving forward, how do you see this program growing or evolving? Will there be other initiatives that address maternal mortality and morbidity?
Well, thank you for asking that question, actually, because I am extremely excited about the possibilities we have at Sutter to contribute both to care at Sutter Health, but also more broadly to care that our patients in California and across the nation receive. At Sutter, we have 35,000 births a year. We have a very diverse population, and we provide care in both urban and rural environments. So there's a great opportunity to learn, and in particular as it comes to health equity, and we think of health equity as a component of quality. We think of health equity as implying that all patients receive the same outcomes. It's not about treating people the same, it's about making sure they get the same outcome. And so that's an area where we feel we have a lot to offer. As you know, the maternal mortality has been increasing nationwide, and whereas since 2006 in California it's been going down. I can say that the national rate, I believe, is something like 23.8 deaths per 100,000 live births, whereas in California we decreased from 16.9 per 100,000 to 7.3 per 100,000 in 2006, and at Sutter Health we're at 3 per 100,000 live births. And we have no disparity with respect to race or ethnicity. And as you know, maternal mortality for Black mothers is a huge national health problem. So the question is, what's going on that we're experiencing those good results and why? And I think having that data enables us to do that. You mentioned C-sections in particular for this particular podcast discussion. And we have found that our C-section rates across African Americans, Asians, Hispanics, and the Caucasian or white populations have no difference. They're all below the Healthy People 2020 benchmark. However, what we did find, there is a race concordance, a concordance between the race mix of the staff and the race mix of the patients makes a difference in decisions to go to C-section. And what that tells us is there is the existence of unconscious bias. And of course, in California, there's now a Senate bill by Senator Holly Mitchell that really is urging, if not, I don't know if it'll be mandated, that we incorporate unconscious bias training in obstetrical clinician training. And we're starting to look at that in terms of understanding how decisions that we make about our patients may, unconsciously relate to differences between the race of the provider group and the race of the patients, which is not to say that, well, first of all, it's to say that diversity and inclusion as part of your workforce is really very, very important. But also, to the extent that you're not able to diversify as much as you would like, or there is this discordance, to understand that there is the potential for bias based upon who you are, what your life experiences have been, and to at least recognize and manage those so that the proper decision making for the patients can occur. So we think those are areas that we really can look at a lot. We're looking also at preterm birth and low birth weight babies where we have not had as much success. We find African American women have a higher rate of low birth weight infants and also preterm births, which is consistent with the statewide data. But, we'd like to better understand that and sort of connect that with also some of the prenatal care we give and social determinants of health. So those are some areas that we're really going to be focusing on. But I think the maternal care issue is, I always say it's sort of a hallmark of our healthcare system is how we treat our mothers and babies, right? And the outcomes they experience. So we're very, very excited about continuing this work and also really learning from others as well. I think this model of DMQCC across California gives us the opportunity to both create and share, but also learn and incorporate best practices from others in the work that we're doing. So that's where we're headed in the future.
It sounds like the integrative approach and family engagement is having a significant and positive impact at Sutter Health. Thanks, Dr. Lockhart, for joining us today and sharing more information about this important program.
Yeah, well, thank you. Yeah. And I should also maybe just add one other comment, which is we do have the benefit of being an integrated healthcare system. So our care is integrated. And what that means, I think, or has meant for the variety of facilities, as I mentioned, there's a great diversity. We have, rural areas in Amador County versus urban facilities in San Francisco, Oakland, Berkeley. But being a system, for example, some of the rural hospitals, the C-section rates tend to be higher in general. But with ours, because we are a system, we're able to provide support for those smaller rural hospitals that may not have some of the access to support that they would need to really achieve the results that we're after. And of course, they have the support of both their colleagues and the sharing of data and the sharing of best practices. So that all helps us quite a bit to have a more consistent outcomes, whether it be the urban or be the rural, each of whom has their own set of challenges. That's been a great benefit to us.
This has been an outstanding example of how engaging mothers and their families and partnering with community resources improves safety and outcomes for mothers and babies. For more podcasts and additional tools, resources, and education to improve outcomes for mothers and babies, please visit the Maternal and Child Health website at www.aha.org/advocacy/maternal and child health. Thanks for listening.